Then we see the Alport syndrome. Alport syndrome, remember there will be the alpha chain of the collagen 4 would be affected. Collagen alpha chain of collagen, alpha 5 chain of collagen 4 would be affected, and in the there will be the one triad would be there. The eyes, ears, and the kidney would be affected. In the eyes, we see the anterior lenticulus would be there. The ears, there is sensorineural hearing loss would be there, and kidney, that is the most commonly we see the basket wave pattern of the basement membrane. The most common presenting sign in case of the RP gene, that is the gross hematuria. So that any nephrotic syndrome you will see the hematuria would be there. The nephrotic syndrome we have studied the minimal change disease, that the mini children. So most common in the children's cause is the idiopathic, and this is also known as the lipoid necrosis. Why the lipoid necrosis? Because lipid is deposited in the PCT. What is the PCT? Proximal convoluted tubules. Proximal convoluted tubule. If you are confused with any short forms, just let me know. Then also known as the lipoid necrosis, there is a nil deposit disease, because the immunofluorescence there is the no findings would be there. That's why we call as the nil deposit disease. Electron microscopy, you see the effacement of the food process. Effacement means the flattening of the food process would be there. The food process would be the podocytes. These are gold standards will be there. And you see the selective proteinuria. The selective proteinuria means there will be the albumin would be released from the urine, and there will be the hyaline and fatty cast will be seen in the urine. Hyaline and fatty cast is seen in the urine. So remember one thing, that is a case of the minimal change disease. That is a minimal change disease. Now the treatment is what? That the steroids, because there will be the some inflammation would be there, and whenever there will be the inflammations, you have to give the steroids. Then we have the focal segmental glomerular sclerosis. That is the most common cause of the nephrotic syndrome in adults. The sclerosis means pink material would be there. There is H3 R square, H cube R square, S1, HIV, hypertension, heroin, reflux nephropathy, renal tissue loss, and we will be having the SCA would be there. On the light microscopy, you are going to see focal segmental sclerosis, hyalinization of the glomuli, and the lipid droplets would be there. Then we have discussed about membranous glomerulopathy, that is the form of the chronic immune complex mediated disease. Primary engine antibody will be formed against the phospholipase A2 receptors, antibody against the thrombospondin, and antibody against the CD2. Which is the most common in the elderly patient? That is the membranous glomerulopathy. The most common in elderly patient is what? That is the membranous glomerulopathy, MGN. The MGN is what? That is the most common in the elderly. Secondary, you have to remember the drugs like due to NSAID, penicillamine, or the gold. Infections, you would be having the HBV, SCV, schistosoma, syphilis, malaria, leprosy. On microscopy, you see the spike and dome type of the pattern, irregular spike from the basement membrane. Then the GMS stain, you see the black color stain or the subepithelial deposition. Membranous proliferative glomerulonephritis, there is a two form would be there. In the MPGN1, there will be the subendothelial deposit. In MPGN2, there will be the intramembranous deposit. Okay, so 2 you can write like the I. 2 you can write like the I. Okay, 2 you will write it like I. So there is intramembranous deposit. And 1 there would be the 1 you can also write I. So the 1 you can't write I because it will be looks like this. So this means this is the subendothelial. Okay, just remember this is the subendothelial would be there. Anyhow you have to remember it. Subendothelial deposit MPGN1 to MPGN2, you will see the intramembranous deposit. This is also known as the dense deposit digit. If you see the RBC cast in the urine, that is seen in the glomerulonephritis, hypertension, emergency. WBC cast in the urine, this is seen in the tubulointestinal inflammation, acute pyelonephritis, and the transplant rejection. Granular cast, this is seen in case of acute tubular necrosis. We will study about the acute tubular necrosis today. That is the muddy brown appearance will be seen. Fatty cast will be seen in the nephrotic syndrome. Waxy cast is seen in case of the end stage renal disease or the CKD. Then I told you some important terminology. If you see the focal means that less than 50% glomeruli are involved. If you see the diffuse means everything is involved. More than 50% glomeruli involved. Proliferative means hypercellular glomeruli. There is a more cells would be there. The more cell proliferation would be there. Membranous means thickness of the gallbladder. Glomerular basement membrane. Thickness of the glomerular membranous basement membrane. So it will be called the membranous would be there. The membranous nephropathy. Lastly, we have seen that there is a kidney. The kidney is affected. In the kidney, you see the lupus nephritis. So there you see the wire loop kidney, and this is the that why we have discussed the primary glomerular disease. It means due to pathology of the kidney or the glomeruli. If you see any other pathology that causing the kidney problem, that is the secondary glomerular disease like SLE. necessarily affecting the kidney. So that's why it is example of the secondary glomerular disease. Okay, is that clear? So let's write down the headings. Acute cystitis. Acute cystitis means there will be the inflammation of urinary bladder. That inflammation of the urinary bladder would be there. So that is what you are going to see in the acute cystitis. So the main thing, whenever you see the cystitis question or there will be the options like acute cystitis, acute pyelonephritis, acute glomerulonephritis, there will be the chronic pyelonephritis. All these type of the options will be there. So whenever you see the cystitis, you will see in the question there is the suprapubic pain. It means if the suprapubic means above the pelvis, so it means this is the seen in, because suprapubic it means this is the pain near the urinary bladder. So that's why we would be having the suprapubic pain in this region. So if the suprapubic pain, that is the inflammation of the urinary bladder. Along with that, you will see the abnormal urine, the dysuria would be there. The patient will see they will say that they increase the urinary frequency. Because why? What will happen? Whenever they will try to urinate, there will be the pain. So when they will stop the urine, so what will happen? There will be the increased frequency of the urine would be there, and the patient will feel some kind of urgency. Would be there. In this condition, you will never see the high fever, chills. Usually they will be absent. So systemic, the systemic sign, if you say like the fever, high chills, so that will be absent. High chills, so these would be absent in the patient. Okay, what will be the risk factor? Just tell me what can be the risk factor in case of the acute cystitis. The female is the risk factor? No. Female urethra is the risk factor, because male urethra is what? They have the penis, so they will be having the long urethra. So they will be having female urethra, they will be small. The female urethra is small, so that's why it is a risk factor for the female. Are more risk factor of acute cystitis than the male because of the small urethra. Other than that, if the sexual intercourse would be there, it means there will be the urinary tract infection, chances are high. So that's why the patient will be having the sexual intercourse, there will be more chances of the cystitis. Then if you are giving any indwelling catheters like the Foley's catheters, if you are putting, and it is non-sterile condition. So if it is non-sterile condition, again there is a high chances of the infection. So that again indwelling catheters is also a risk factor. The diabetes mellitus, it is also what? That is the risk factor, because diabetes mellitus, it means we will see the sugar in the urine or the glucose in the urine. If you see the glucose in the urine, it will attract the more bacteria, and if it will attract the more bacteria, the more chances of infection, then there is more chances of the inflammation of the urinary bladder, and there will be the impaired blood emptying. Okay, everything is clear. देखो female urethra क्यों? Why female urethra? Because that is the small. ठीक है? Male क्यों नहीं? Because male have the penis, so they will be having the penile urethra. ठीक है? Sexual intercourse, because if the sexual intercourse, like they will be having sexually transmitted disease, so there will be the chances of the E. coli bacteria that can spread to the so that will cause the urinary acute cystitis. Indwelling catheters, like if the non-sterile catheters are there, and so there will be high chances of the spreading of the E. coli bacteria, or the any bacteria can be infected. Diabetes mellitus, they will be having the glucose in the urine, so the glucose will attract the more bacteria, and like for example E. coli, the staphylococcus, so they will Klebsiella. So that's why we'll be having the diabetes mellitus is also a risk factor. And impaired blood emptying. If you will not able to if you will not do the, like if you will keep filling the urinary bladders, there will be high chances of the infections that can be developed in this patient. So the causes, you remember, the causes we have discussed.
What is the meaning of impaired blood emptying?
Here is also the cause is E. coli. E. coli is the most common cause. Escherichia coli. Escherichia coli is the most common. Then we can be having the Staphylococcus saprophyticus. We can be having the Staphylococcus saprophyticus. This is Staphylococcus saprophyticus. We have seen that this sexual intercourse is the risk factor. So this is seen in sexually active young women. This is seen in sexually active young women. Okay, this is seen in sexually. But again, if you say the E. coli, again that is the most common. Okay, E. coli is the most common, but if you say about the Staphylococcus saprophyticus, this is sexually, it is more common in the sexually active young women. Then if I ask you which is the most common in the sexually active young women, again it is the E. coli. Okay, this is the bacteria that is common in the sexually active female, but the sexually active young female I say that is the E. coli again. Okay. Then we would be having the Klebsiella. The Klebsiella can also be there, and there will be the Proteus. And if the Proteus would be there, you will getting to see urine has the ammonia scent. Has ammonia, like the ammonia smell would be there. The ammonia kind of the smell. So that will seen in the Proteus, or the urine has ammonia kind of the smell. If you say about the lab investigation, if you say talk about the lab investigations or the lab report, in the lab report there will be the high chances of the leukocytes would be high because there is a bacteria. Dekho, if any bacterial infection would be there, there is a high chances of the leukocyte esterase enzyme would be increased. Okay, then we would be having the nitrites would be there, the nitrites. NO3 negative. These nitrites would be high. If you see the lab report, you will see that the patient will be having the more amount of esterase enzyme, the more amount of the nitrates enzymes would be there. And if it is the nitrate enzymes, it indicates the Enterobacteriaceae. Okay. Then what you are going to see here, there will be the pus or the like bacterial infection will be there. So pyuria would be there. The pyuria will be there. Okay, and along with that you will see the pyuria basically usually we will see in the patient will be having the chlamydia type of the infection. Okay, so this the lab investigation, that on the lab investigation you see the nitrites would be high, pyuria would be high, and they will see the esterase would be high. So this is the risk factors: acute cystitis, inflammation of the urinary bladder. You are going to see very important feature, that is the suprapubic pain. The suprapubic pain is very important keyword for your Pro 2 exam. Okay, after that you see that this urinary frequency would be high. There will be the urgency, the patient will feel the urgency, and there is some systemic sign like fever, high chills, that will be absent. Then we have the risk factor. The risk factor like we have the female urethra, because female urethra is the small urethra, so that will be causing the more infection, sexual intercourse, indwelling catheter, diabetic mellitus, impaired blood emptying. The cause, remember that the E. coli, the same as in acute pyelonephritis. Staphylococcus saprophyticus, that is the sexually acting young woman. Then we have the Klebsiella, then we have the Proteus. The urine has the ammonia kind of the smell. Lab investigation, remember, you will see the esterase enzyme would be high. Along with that, the nitrates would be high. And if the nitrates is high, it tells us that there is a, it suggests what, that indicates that Enterobacteriaceae enzyme and Enterobacteriaceae bacteria is present. Along with that, you see the pyuria. The pyuria you can see in the patient in Neisseria, or if it is any case of the chlamydia infections can be there. So that is what indicates about the pyuria. Then if you say about the treatment, remember, for the treatment you have to give the patient the antibiotics. You have to give the antibiotics. And what kind of the antibiotics you will give? Trimethoprim sulfamethoxazole. Okay, trimethoprim sulfamethoxazole. Okay, and we also call this as a cotrimazole. We also call this condition as, also known this drug, common name, brand name of this drug is the cotrimoxazole. Okay. So that is what trimethoprim or sulfamethoxazole that we can give in this patient. This is the mixture. The cotrimoxazole is a mixture of the trimethoprim as well as the sulfamethoxazole. Also we can give the nitrofurantoin. So these are the two drugs that we can give in the patient with acute cystitis. ठीक है? In the E. coli infections. Is that clear? So now let's come back to our questions. In the question we have discussed about the acute pyelonephritis, glomerulonephritis, cystitis. Then we would be having the urolithiasis. Urolithiasis we will discuss when we will discuss about the kidney stone. At that time we will discuss. This metabolic nephropathy, there is nothing like that. Okay. Now question number 8. A 8-year-old boy has suffered from the tonsillitis or the pharyngitis. In 2 weeks he started complaining of the migratory joint pain. Okay, there is a migratory. Migratory joint pain will be seen in which condition? Acute rheumatic fever. The edema of the joints, restriction of the movement. On examination you see there is acute rheumatic heart disease, activity of the 3rd degree, primary pneumocarditis is also there, polyarthritis is also there. So you have seen the patient is what? They having suffered from the tonsillitis. In 2 weeks he started complaining of the migratory. So this means the patient is having firstly there is a sore throat, pharyngitis, tonsillitis, and after that the 2 weeks we have seen that this patient is having some kind of following the Jones criteria. So it means this is having the patient with the acute rheumatic fever. And in acute rheumatic fever we are seeing that the patient is having the carditis, we have the arthritis. So everything we have discussed in the Jones criteria. What medication is to be prescribed? So I tell you the prophylaxis of acute rheumatic fever. Okay, prophylaxis of acute rheumatic fever I told you that is the penicillin, that is the penicillamine. Okay, that is the penicillin, benzathine penicillin that I told you. So this is the prophylaxis that we have to start. But here you can see that patient is having the polyarthritis, means inflammation is there. And if any kind of the inflammation would be there, what you will give? Inflammatory agents. What you will give? You will give the inflammatory agents. You will give the inflammatory agents. What are the inflammatory agents? Like we have the steroids and non-steroids. Steroids and non-steroids. Okay. Non-steroids we will be having, like we have the paracetamol, we having the aspirin, we have the diclofenac, we have the aceclofenac, we have the ibuprofen, we have the celecoxib, we have the rofecoxib. So these are the non-steroidal anti-inflammatory drugs. So what here we will be having, that is the steroids. So prednisolone is what? That is the steroidal drugs will be given. I hope every one of you are not confused with the steroidal and non-steroidal. I hope every one of you studied about the Cox and Lox pathway. Yes, give me thumbs up if you have studied, if you remember this. If you not remember, just give me thumbs down. If not remember, thumbs down. If remember, then put the thumb. देखो Cox and Lox pathway, actually this is the physiology. So what you have seen, there is a phospholipid. We have the phospholipid. The phospholipids is what? The phospholipid, it is the component of the cell membrane. So what if the phospholipid, it will be converting into the arachidonic acid. It is the 20 carbon compound. It is the 20 carbon compound. So the phospholipid will be converting into the arachidonic acids with the help of one enzyme, that is the phospholipase A2. With the help of enzyme that is known as the phospholipase A2. This arachidonic acid will be converting into the two pathways. The one we having the Lox pathway and one we would be having the Cox pathway. Okay, the Lox means lipooxygenase. And Cox means we would be having the cyclooxygenase pathway. The Cox pathway, remember, we would be having the Cox 1, Cox 2 and we would be having the Cox 3. Okay, the cyclooxygenase pathway, we have the COX-1, COX-2 and the COX-1, COX-2 and COX-3. ठीक है. अभी देखो, now what we will see that in case of the, we would be having the, here the phospholipid is converting into the arachidonic acid, that is the 20 carbon. So here it will be, there is the like pathway, the metabolic pathway is there. So that you have to remember. So if you see the cyclooxygenase, in the cyclooxygenase what will happen, there will be the formation of the, like prostaglandin. There will be the prostaglandin I2, the thromboxane A2, okay, and there is a PGD2, PGE2. PGD2, PGE2. So these are the some prostaglandin formation would be there. Now if you see the what the function of the prostaglandin I2, they inhibit the platelet aggregation. The PGI2, what they do, they inhibit the platelet aggregation, okay, let me write it here, otherwise you confuse. So they will be having some kind of the compounds would be there, like we would be having the PGI2, we having the thromboxane, that is known as the prostaglandin, okay, then we would be having the thromboxane, and we would be having the prostacyclins, okay, that is the prostacyclins, you can say PGD2 and PGE2. This is the types of the prostaglandins. So if you see the PGI2, what they will do, they inhibit what? They inhibit the platelet aggregation. And at the end also cause the vasodilation. They will cause the vasodilation. Thromboxane, what they will do, they promote the platelet aggregation. This is the PL means, okay, let me write it full. The platelet aggregation. And what they will cause? They will cause the vasoconstriction. PGD2, PGE2, what they will do? They increase the vascular permeability. And they will cause, if the vascular permeability is increasing, again they will be cause the vasodilation. देखो ये तो पता ही होगा ना, you know already that what is the vasodilation and vasoconstriction. When there will be the vasoconstriction, it means the vessels are constricting. If the vessels are constricting, there is increase of the pressure, and if the vessels are dilating, it means there is a decrease of the BP. And also if we talk about the lipooxygenase, the LOX pathway, what they will do, they will release the leukotrienes. And these leukotrienes are responsible for the bronchoconstriction, bronchospasm. These leukotrienes are responsible for the bronchoconstriction. They increase the vascular permeability, means vasodilation. So if the bronchoconstriction would be there, they will cause the asthma. They will responsible for the asthma. So the leukotrienes. So if we can give the leukotrienes inhibitors to prevent the asthma, and if we will inhibit the leukotrienes, it means we can dilate the bronchus. So we can give the leukotriene inhibitors. So that why we can give. The same like if we say about the COX, then we have seen based on this pathway we have discussed some drugs. And in between the drugs we have discussed that the COX-1 drugs. We have discussed non-steroidal anti-inflammatory anti-inflammatory drugs, the NSAID. So we have discussed the non-steroidal anti-inflammatory drugs. Okay, we have discussed this drugs. We have discovered these drugs. Now what you see, we have seen that let's inhibit the COX-1. So we have got the COX-1 inhibitor. What we have got? We have got that there is a let inhibit the COX-1. Okay, we have seen that firstly it was there like let's inhibit the COX inhibitor. So once they will inhibit the COX inhibitors, we have got that there is one drug that is known as, for example, aspirin. Let's say aspirin would be there. The aspirin. Then we have seen that there is a drugs like the ibuprofen. Then we would be having the diclofenac. Okay, like these kind of the drugs would be there. So if there is drugs, what we got the some side effect. What the side effect? We got that this patient is, they will cause the gastric problem. They will cause the gastric problem. Means what they were causing? They was causing the peptic ulcer. They was causing the peptic ulcer. So okay, then we have divided the COX into the three pathways: the COX1, COX2, and the COX3. So the COX1 we have discussed that we have given this as the name COX1. After that we have seen that there is a, let's give the COX2, the COX2 inhibitor. The COX2 inhibitors we have made like the celecoxib, rofecoxib. So they was also inhibiting the COX like cyclooxygenase enzyme, but then we got that they also having some kind of the side effect, like they are the cardiotoxic. Then we have discovered the drugs like the COX3 inhibitor. Then COX3 we have seen that there is a like paracetamol. The paracetamol is also having one side effect like the hepatotoxic. They are the hepatotoxic, but the hepatotoxicity will be there when you will take around 30, 50 drugs at a particular time, at the same time. Okay, so that one can cause the hepatotoxicity, but and it will be like for if you will take it for a very long time, then it can cause the hepatotoxicity. Okay, ibuprofen, they can, you will I have feel that the ibuprofen there will be some kind of the pain will be there in the gastric in my stomach, so that's why the ibuprofen, the aspirin, diclofenac, they can cause the peptic ulcer. Okay, so these are the drugs like based on this cyclooxygenase pathway. Now if we say that we have seen that okay, if I inhibiting the COX1, if I inhibiting the lipoxygenase also, but we are not getting the result. So somebody has, some scientist came or some pharmacist came and say that inhibit this enzyme. But which drugs can inhibit this enzyme? That is the steroidal drugs. That is the steroidal drugs. Okay, these prostaglandins, these thromboxane, all they are involved in the inflammation. They are involved in the inflammation. Okay, if you inhibit the root, if you inhibit the root cause, it means inhibit the phospholipase A2. There is no arachidonic acid formation. There is no LOX formation, no COX formation, no prostaglandins. That means the prostaglandins is also involved in the inflammation. They are also involved in the inflammation. So okay, so that is what, if you inhibit that we can prevent the inflammation. Okay, that's why we can prevent the inflammation. Okay, the phospholipids are present in the cell membrane. So that's why we will be having the two kinds of the drugs. One we have the steroidal drugs, and another we would be having this COX inhibitor drugs, that is the non-steroidal anti-inflammatory drugs. So these are the COX inhibitors. These are the COX inhibitors. The LOX inhibitors like leukotriene inhibitors like jalutron, है ना? So Montelukast, they inhibit the leukotrienes. They inhibit the leukotriene, LT4. They inhibit the leukotrienes. Okay, jalutron, Montelukast, they all are the leukotrienes inhibitors, LOX inhibitor. Okay, is this clear? Should I repeat it or is it clear? Okay, so we would be having the cell membrane. The cell membrane component is there, that in the presence of the phospholipase A2, it will become the arachidonic acid. So this is the whole biochemistry, or including the physiology as well, including the pharmacology as well. Because arachidonic acid, they will be having the metabolic pathway, LOX, COX, leukotrienes, prostaglandins, thromboxane, prostacyclins. So they will cause the vasodilation, vasoconstriction, inflammations would be there. So they will be responsible. Prostaglandins, they are the inflammatory agents. They will cause the inflammation. So that's why we will be having the inhibitors of these prostaglandins, prostacyclins, thromboxane. like the COX-1, COX-2 inhibitors. Based on that, we have discovered these kind of the drugs. These are all are the non-steroidal anti-inflammatory drugs because they prevent the inflammation. So that's why we can give the here in the case like the arthritis problem would be there, the prednisone. Along with that, we know that this is the due to which bacteria, that is the group A beta hemolytic streptococcus bacteria. So that's why in this case we will give the antibiotic drug. What antibiotics we can give? We can give the penicillin. And if the somebody, because lots of the patient they are also allergic to penicillin, so in that cases if allergic, then we can go for the erythromycin. If allergic, we can go for the erythromycin. Erythromycin होता ना? Let me just check. हाँ, erythromycin, ठीक है. So if allergic would be there, then patient is allergic to the penicillin, then we'll start with the erythromycin. Okay. And we have to treat the other symptoms also, like if the patient is some kind of the pain would be there, then symptomatic treatment. If the fever would be there, we can give the paracetamol. If the pain is there, then we can start with the some kind of the painkillers. Okay, and other complications also we have to, of course, note of course, if any patient with acute rheumatic fever, you will not just give the one drug, you know. You will see in the when you will go to the hospitals, you will see there the lots of the patients will be there, and those patients will be having that they will be treated with the lots of conditions, like you have to start the long list of the drugs, because sometimes what happens, there will be the side effect of one particular drug, so that's why you have to give the that drug also. Like for example, if the some drug have the side effect of vomiting, so you have to start the MSAT also, the ondansetron, that is the drug for the vomiting. ठीक है, MSAT 40 mg, 20 mg. ठीक है, don't worry about anything. देखो, now you will feel that a patient with the acute respiratory viral infection, ARVI, third day of the disease, complaint of the pain in the lumbar regions, nausea, dysuria, oliguria, urine analysis shows the hematuria. There is a hematuria is there. If you don't know about anything, what you will mark? If I say that this is, if you don't, let's suppose there is a 5 options are there, and you have seen the question. Now what you will mark here? Will you mark the acute renal colic? Why you will mark the B? The answer is in front of you, acute interstitial nephritis. The answer is in front of you. See, will you mark the acute renal colic? If you don't know about this question, that like there the some question would be there that you have never studied about those questions, but they every in all the questions, because if you study this much, of course there will be the some keywords will be always be there in your mind. So that's why if I am saying that the patient is acute respiratory viral infection, you saw the pain in the lumbar region, dysuria, oliguria is there, है ना, hematuria is there. Okay, hematuria is there, acute respiratory pain. Okay, specific gravity, the blood creatinine, but you don't know about the blood creatinine, and potassium level, that is the 6.4. What is the normal level of the potassium? Write me in the chat box. What is the normal level of potassium?
3.5 to 5.5.
नॉर्मल लेवल ऑफ पोटेशियम कितना होता है? नॉर्मल लेवल ऑफ पोटेशियम कितना होता है? और कितना होता है? बताओ. What you will mark? Hematuria is there, oliguria is there, and I told you that is देखो acute glomerulonephritis. Of course, you will not mark the acute cystitis because they have not mentioned anything related to the suprapubic pain, and the patient is also acute respiratory viral infection. If till now, I hope you understand that cystitis, pyelonephritis, these are the some ascending infections. Okay, they will start from the urinary tract infection. Acute renal failure. The acute renal failure, of course, that will be not the answer. The acute renal failure means everything is gone. Okay, the renal is not working, the kidney is not working. The acute, you have studied there is a glomerulonephritis, In the glomerulonephritis, you have studied the nephritis. So just mark that. Okay. If you find such kind of the questions, do like that. If you say the glomerulonephritis, mark the nephritis. If in the glomerulonephritis you have studied about the nephritis, so this will be the better answer. Acute glomerulonephritis is the better answer than the glomerulonephritis. Now let's study it about the AIN. What is the AIN? Acute interstitial nephritis. That is the acute interstitial nephritis. So in acute interstitial nephritis, wait a second. Acute interstitial nephritis, also known as the tubulointerstitial nephritis, and in which you will see there is acute interstitial renal inflammation. This is the type 4 hypersensitivity. Type 4 hypersensitivity, we would be having CD4 positive T cell in the interstitium, and it is the reversible cause of the AKI. The cause here, remember, it immunologically induced hypersensitivity to the drug. So it will be the 5 P's you have to remember. So P diuretics like the furosemide, we have the spironolactone. The spironolactone is the potassium sparing diuretic. We have the acetozolamide. The acetozolamide is the drug for which sickness? Motion sickness or mountain sickness? Drug of choice for the motion sickness we can give. Then we have the thiazide. The thiazides, we have the drugs like for the hypertension in the patient with the hypertension. Okay, yeah, this is motion sickness. Then we have the P. The P we can have the diuretics. Another P, remember, we would be having, that is the penicillin. Another one we would be having the penicillin. That is the penicillin and cephalosporin. Penicillin and cephalosporin. We have P, remember, pain free. Pain free. Who will help in the pain free? That is the some NSAID. The inflammations, they also use for the diclofenac. We have give the diclofenac to prevent the inflammations and the pain. Then we have the P, the proton pump inhibitor. The proton pump inhibitor. What is the example of the proton pump inhibitors? Like omeprazole, pantoprazole, these all are the proton PPI drugs. Then we have the another P, we would be having rifampin drugs. Then we have the some sulfur drugs also, sulfur drugs, PS. Okay, that you have to remember, please. Just the short form you can remember, PS would be there. So there will be the P, and diuretic drugs, penicillin and the cephalosporin. Then we have the pain-free drugs like the NSAID, we can be having the PPI, proton pump inhibitor, and we have the rifampin or the sulfur drugs. They all cause what? They all cause the acute interstitial nephritis. They all cause the acute interstitial nephritis. Is also known as the tubulointerstitial nephritis. Okay, is that clear? Now, what will be the clinical feature that you are going to see in case of acute interstitial nephritis? The patient with the acute interstitial nephritis, they will come asymptomatic. They will be having no symptoms you will going to see in the patient with the AIN. There will be the asymptomatic patient would be there. The asymptomatic patient would be there, and you will see the patient asymptomatic usually. There can be the symptoms. There you will see there is a no edema would be there, no history of hypertension, so anything not be there. So it means you have to see that patient in which you will see the patient with no edema, no hypertension, and along with that you will see the patient having the rashes. And the rash you seen on the body, this is the most common extra-renal manifestation or the extra-renal symptoms. On the lab investigation, you are going to see eosinophilia. You are going to see the eosinophilia. And these rashes, they are the maculopapular rash. These are the maculopapular rashes would be there. Maculopapular rash would be there. there will be the eosinophilia, means increase of what eosinophils would be there. Okay, and we have discussed that this is a reversible cause of acute kidney injury as well. Okay, and causes, remember, the immunologically induced hypersensitivity to drugs, and remember that sometimes some systemic infection is also there. This is the first point, and the secondly, it can be due to some systemic infection as well. The systemic infections like the mycoplasma, autoimmune disease like the Sjogren's syndrome, mycoplasma can also cause acute interstitial nephritis. Then we will be having like the some autoimmune disease. The autoimmune disease like the SLE, Sjogren's syndrome that we have discussed, the Sjogren's syndrome, and we would be having the sarcoidosis, the connective tissue disorders. So all these can also cause the acute interstitial nephritis. So what we have discussed till now, the acute interstitial nephritis is the acute interstitial renal inflammation. Means that the space between the some renal vessels, that the interstitial space that will be inflamed. And this is also known as the tubulo-interstitial, because between the tubules we will be having some kind of the space that will be inflamed. And this is an example of the type 4 hypersensitivity. It means this is the T cell mediated hypersensitivity, and this is the reversible cause of acute kidney injury. The cause, remember, this is immunologically induced hypersensitivity to the drugs, like we have the 5 P's would be there, the diuretics, penicillin and the cephalosporin. The pain-free drugs like the NSAID, PPI like proton pump inhibitors, and the rifampin, and we have the sulfur drugs. Then we would be having the clinical feature, the asymptomatic usually, there is no edema or hypertension. The rashes would be there, like the most common extrarenal symptoms would be there, the maculopapular rash and the eosinophilia. And you will see the eosinophilia. Along with that, you will see the azotemia also. Can anyone tell me what is azotemia? Azotemia, what is that? Azotemia, what is that? What is
Um,
azotemia?
as, as,
I think I
Azotemia
have
is
tell
a
you this
condition of
earlier.
having a lot of nitrogen in
So
the
I
blood.
remember. Ho, ha. So ha, H, A था ना, तो A means azotemia. What is azotemia? Themia. Azotemia. Very important one. So because all the nephrology part is very important. Whether it's the creatinine, whether it's the blood urine nitrogens, because every time you have to do, because all the drugs is also filtered from the kidney. So like if the patient is having the neurological manifestations of the herpes simplex virus, HSV1, like this patient has came in the ward and was admitted in the ward, and I think this today is the 11th day, and we was giving her the acyclovir. So this is today is the 11th day of her acyclovir, and we are giving he was diagnosed with the HSV1, herpes simplex virus 1. So she is having we have to give the routine KFT in this patient, and along with that we have to check about the dehydration also, because the acute KFT would be there. So in the KFT, remember that if the patient would be having the HSV1, why we are doing the KFT? Because of this condition, acute interstitial nephritis, because there is high chances that this patient will be having developed, because on the acyclovir the patient can go into the acute interstitial nephritis, because this is due to some drugs or the injection of the acyclovir. Okay, that's why all the nephrological part, the KFT, the kidney function test, the kidney pedia, this is very important for all other systematic infection as well. Okay. Okay, so this is what we having the acute interstitial nephritis. Now you can see the patient is what? Acute respiratory viral infections. So acute respiratory viral infections, there can be some kind of the infection is there. I told you there can be sometimes the infection can be there. And also the acute respiratory viral infection, we have to the third day of the disease, so some medication has to be started in this patient. So after that they have not mentioned that is the wrong thing. The complaints of the pain in the lumbar region, so the pain in the lumbar region, again they have to give the medicines like the painkiller or the NSAID, due to which we have got the hematuria, the specific gravity. The creatinine level is 0.18. So creatinine level usually what you will see, that is a 0.7 to 1.1. 0.7. So this is in the normal range. Okay. So that the potassium level is little bit high. The potassium level is on the high side. If the creatinine level is very much higher side, it means there is a high chances of the renal failure. But there is a no creatinine level on the higher side. That's why we would be having no acute renal failure would be there. The only remaining options we would be having, that is the acute interstitial nephritis. Okay, is that clear? And also remember the cast here, the cast in the urine. The cast in the urines, like we would be having the muddy brown cast. The muddy brown cast or acute or renal tubular cast. देखो, these cast I told you in case of the acute tubular necrosis. Acute tubular necrosis. So this is the more specific for the more suggestive of acute tubular necrosis. Or we have the also seen in the AIN, but again the more suggestive of the acute tubular necrosis. Okay. I hope you are not feeling that I am teaching you much in detail. If it is like that, just give me thumbs up, and if not, just give thumbs down. ज़्यादा लग रहा है? अगर ज़्यादा लग रहा है तो थम्स अप करना है. हाँ, ठीक है. Rose, what about you? ज़्यादा है. Okay. It's more high, but this is not more. Once you will able to do the questions, you will understand it. As we have the enough time for the my exam, है ना? So that's why we would this is the enough. Note 5. Okay. So acute interstitial nephritis, we would be having the very important role, and everything will be coming because I am repeating it again. I am repeating it again. So that's why it's becoming longer. But these, if you will able to understand it and you will able to revise it, it will become very easy for you. Okay. All these things like the type 4 hypersensitivity, reversible cause of acute kidney, all these details you will see in the question itself. All these details, like you will see in the question, you are seeing the acute respiratory viral infection. So ARVI is there, the acute respiratory viral infection. You have to see that acute respiratory viral infection, they will start any drugs in this patient. So in this patient, if you started with any drugs or any systemic infection is there is a high chances of the kidney damage. Okay, so high chances of the kidney damage. So in this patient, there is a more cases of the nephritis will be there. The inflammation causes would be there. Because there will be no symptomatic usually. All these findings you will see. There will be no typical findings you seen in the question. I will give you the question with the acute interstitial nephritis, in which all clinical things would be there. Okay, these are the some questions not fully completed. So that's why you will be having such kind of the issues. Okay, the another one we would be having the acute tubular necrosis. Acute tubular necrosis. This is the last for today. Okay. The acute tubular necrosis. The acute tubular necrosis, remember, this is the most common cause of acute kidney injury. The most common cause of acute kidney injury, AKI. The most common cause of acute kidney injury in hospitalized patients. And usually it resolves spontaneously. Okay, it can be the fatals, like when during the patient is having some kind of the low urine output, means oliguria condition would be there, so there will be there. Then acute tubular necrosis, you will see there will be the granular cast. there will be the granular cast, and I told you that is the more suggestive of the acute tubular necrosis. This is also seen in AIN, but again this is the more specific for the acute tubular necrosis, and often you will see there will be a muddy brown appearance. The muddy brown appearance granular cast would be there. Okay, that you have to remember. There is again you will see that there is some kind of the stages would be there. The first we would be having inciting events, then we would be having the maintenance, then we have the recovery phases. So all these things would be there. But again we have not going into the detail of that. The main thing here that it can be caused by the like some kind of the ischemic or maybe nephrotoxic injury. Like ischemic means like if there is a decrease in the, it is caused by the ischemic injury, like the decreased oxygen supply to the organ or the kidney, or we would be having the nephrotoxic injury. Nephrotoxic injury. Okay, so that can be the reason. So here the ischemic means like for example if there will be like the secondary to the renal blood flow, if there is a decrease in the renal blood flow, so that will be lead to the death of the tubules, and the death of the tubules is responsible for the necrosis of the tubules. The necrosis of the tubules is what? There will be the decreased oxygen supply, and once the decrease in the oxygen supply, the tissue or the tissue or the cell or any of the organs that will be damaged, and that will be damaged, and finally they will end up with the necrosis. The necrosis is what? That is the cell death phenomena. And same like the nephrotoxic, so it is like from the toxic substance. The nephrotoxic injury like due to some kind of the aminoglycoside. Lead, cisplatin. So all these can cause the nephrotoxic injury. So if the patient would be having some kind of the aminoglycoside treatment, the lead, cisplatin, ethylene glycols, okay, or there will be the myoglobinuria. So in this patient we have to keep checking about the necrosis part, or we have to keep checking about the KFT also. So if you do the KFT, the kidney function test, in that you will keep checking about the granular cast. If you are getting the granular cast, it means or the blood urea nitrogen or the serum creatinine level is high. There is a high chances that there is a patient is going under the necrosis, and if it is going under the necrosis, this is become the most common cause of acute kidney injury or the acute kidney failure. Okay, so that's why we have to keep checking about the KFT in the patient acute tubular necrosis. The necrosis part means this is the cell death phenomena. The cell death phenomena, that the two conditions, ischemic or due to nephrotoxic. So ischemic, like if there is a decreased renal blood flow. If there is a decreased renal blood flow, means this will become the ischemic. Okay. So this is the thing that you have to remember. So here is your question, that is acute interstitial nephritis, and everything we have discussed already. The acute kidney stone we will be going to discuss later on. Okay, let's do one more question. A neonate was born from the first gestation on the tongue. The jaundice was revealed on the second day of the life, then it became more acute. The adynemia, vomiting and hepatomegaly were observed. Indirect bilirubin, you can see that the 275. Direct bilirubin is very less. Hemoglobin is 150 gram. Mother blood group is ORS42. So we are just going to discuss here the hemolytic disease. So we are going to discuss here about the ABO blood group. Okay? The blood group. We have the two kind of the blood group we are going to discuss here. The first we would be having the ABO blood grouping, and we would be having the RH blood group, RH grouping. ठीक है. अब देखो ABO blood grouping में क्या होगा? There is a 4 kind of the blood. ठीक है. So first we are going to discuss this one. So we have the 4 type of the blood group. A blood group, B blood group, type A, we have the type B, type AB, and type O blood group. ये 4 blood group होता है, 4 blood group are there, right? Now see, if we talk about the type A blood group, what does it mean by the A blood group? It means they have the surface antigen. The surface antigen, that is the I. We denote with the help of the I. So they have the A antigen should be there. So we have write it like here that they having the A antigen. They have the A antigen. Okay. So if we talk about the B blood group, so B blood group, it means they have the surface antigen, that is the B. So they will be having the B antigen would be there. Then AB blood group means they would be having the A and B antigen. They would be having the both kind of the antigen would be there. The O antigen means they have the no antigen. They have the no antigen would be there. Okay, the type A, type B, type AB or type O. So A antigen, B antigen, AB antigen, and we would be having the O means we have the no antigen. So no antigen, they don't have any antigen on their surface. AB type AB blood group means they have the both antigen, A antigen also and B antigen also. The same like if we say about the antibody. If we talk about the antibodies, देखो, now what will give, for example, I have give the blood. I have, for example, A blood group. I have the A blood group. So this is the I have the A blood group. Now I am taking the blood from the A blood group. I am taking the blood from the A group. So it is compatible. Okay, I can take the blood from the A blood group because they have the same surface antigen. It also having the A antigens, IA. It means also having same antigen. They also having the same antigen. Okay, so the antigen are the same. So I will not make any antibodies against anybody. But if I, let's suppose, if somebody having the B blood group, and I am taking the blood from the B blood group, I am taking the blood from the B blood group. What they have the antigens? They are in the IB and the IB antigens. I have the IA antigen. They are not similar like my antigen. They are not similar like my antigen. So this is the foreign particle for me. This is the foreign particle for me. So I will make the antibodies. I will make the antibodies against this. I will make the antibodies. I will try to kill them because they are the foreign bodies for me. And I am very desi person. And I am very national person. So that's why I will make the antibodies against any foreign particle. Okay, so that antibodies formation, and I will make the antibodies that I will denote by the B. I will denote it by the B antibody. So the B will become the B antibodies that I am forming, that will kill the antigen B. So this will become incompatibility, ABO incompatibility. So here what I can see, we will be having there is a B antibody. Or should I, can I remove it now? Okay, so we will be having here, in this condition, we would be having the B antibody would be there, the B antibody. The same like we would be having here the A antibody, the antibody against the A blood group. Here we will see, like for example, if I say I have the A blood group and I have the B blood group. Okay, and for example, if I am taking the blood from the A blood group, the A blood group have the antigens IA. Okay, I have the blood group IA and B antigens. That is the both antigens, A antigen also and B antigen also. If I am taking the blood from the A blood group person, so if I am taking the blood group from the A blood group person, it means I also having the A antigen. So this is my similar antigens would be there. So I will not make any antibody. The same like for example, if I am taking the blood from the B blood group, then if I am taking the blood from the B blood group, I also having the same antigens like the IB having like the B blood group having. So it means I will not make any antibody. So I can take the blood from the A antigen as well as also I can take the blood from the B antigen. So it means they don't have any antibody. No antibodies would be formed. The type O, let's see. For example, if I having the type O blood group, the type O blood group means I having the no antigen. If I having the no antigen, let's suppose there is a three blood group, three person is there, and one person having the A blood group, and he is offering me the blood. He is offering me the blood. I having the O blood group. Now I can see that this having the A antigens. What will happen? I don't have any antigens like similar antigens like the A antigens. So I will try to make the antibody against them. The same like the same like we would be having the B antigens. The same I will try to make the antibody. The same like you have the A B antigens. So I will try to make the antibodies A or B. So it means they having the both type of antibody. They having the both type of antibody. They are the no antigens, but they have the both antigens A or B antibody would be there. Okay, is that clear? Yes, ये समझ आया? Is it clear? So that's why we can say that they have the no antibody. So we can call this as the universal recipient. They can take the blood from anyone, like they can take the blood from O blood group because O don't have any antigen, so it will give directly blood to the AB. Then type O is what? The type O is the universal donor. They can give the blood to anybody. The same like we would be having the another blood group system, that is the RH blood group. The RH blood group. This is the very simple. There are the two types, RH positive, RH negative. The RH positive means they have the some factor would be there, the rhesus factor that is firstly discovered in the monkey. So they have the rhesus factor would be there. RH means rhesus. So the rhesus factor is present. The rhesus factor is absent. The rhesus factor is absent. Okay. For example, let's take a example of mother and father. So let's suppose this is the mother and this is the father. The mother having the blood group RH positive, mother having the blood group RH positive, father having the blood group RH negative. Okay, so what will happen? Let's suppose the child also got the blood group RH negative. Okay, so what will happen? The child having the RH negative, so it means that no antigen is there, and they having what antigen? They having the antigen. They having the antigen is present, that is the rhesus antigens. Okay, so now they have no antigens and they have the antigens. So blood, the fetal blood group will be going to the mother blood group. So there will be the no compatibility. Why there is a no compatibility? Because no antigens and the no antibody form will be there. But if it is the same conditions, like if I say the mother is RH negative, if this is the mother and this is the father, if the mother is RH negative and the father is RH positive, and also the child is what? That is the RH positive. The child is RH positive means the antigen is there. Now the blood will be going from the fetal to the mother, fetus to the mother side. If in mother, the blood is going from the fetus to the mother side. Now when the blood will going to from the fetus to the mother side, they have the RH antigen. So what will happen? The mother will form the antibody. The mother will form the antibody. Okay. Now this fetus will be delivered after 9 months. This is the first fetus. So there will be no problem. There will be the no problem in this fetus. But the same when the second fetus would be there. The second fetus, again let's suppose it is the RH positive. Now mother have what? Preformed antibody. Now mother have what? Preformed antibodies. So they will attack this RH positive child, and they will lead to the hemolytic disease or the jaundice in this patient. Hemolytic disease or jaundice. And we call this condition as the erythroblastosis fetalis. Erythroblastosis fetalis. Is this clear? We call this condition as the erythroblastosis fetalis. So if it is such kind of the conditions, there will be the first child will never be affected. The second child will be affected because mother has already made the preformed antibodies would be there. Then we have the B cells, the B cell. Then normally we have the B cell and the T cell. So B cell having the B memory cell also. The B memory cells, they will make the antibodies and they will having the memory of the previous antigen. So that's why they will make the preformed antibodies before that. So these preformed antibodies will attack the second child. Okay, is that clear? That's anything you want to ask in this question? कल पूछूंगा मैं ये. Tomorrow I will ask you this, and I will give you the question and I will ask, like in the next class. So if you have any problem, just let me know. Rose, did you understand? Akram? Did you understand it or not? Hello Rose, are you here? Okay, from tomorrow you have to open your video. ठीक है?